Morning everyone. Today I'll be taking you through a short talk on scaphoid fractures. So this is what we'll go through today. And starting with the anatomy of the scaphoid. So the scaphoid, the name is derived from the Greek word scaphos, meaning boat, and it's the largest bone in the proximal carpal row. So highlighted down here, and as you can see, you can imagine, looks like a little boat. So in terms of its anatomy, it articulates proximally with the radius, distally with the trapezium and the trapezoid of the distal carpal row, and medially with the lunate and the head of the capitate. And it's associated with several important ligamentous structures, which I've highlighted in red, particularly the radioscaphocapitate ligament. And this ligament prevents ulnar translocation of the carpus. It's also important in the pathology of scaphoid fractures, which we'll get onto in just a moment. Also worth noting is its vascular supply. So in terms of its arterial supply, the scaphoid receives supply through perforations on the bone's dorsal surface from branches of the radial artery. And in the majority of the individuals, it's quite a tenuous supply. So the supply enters the distal part of the radius, of the scaphoid, and travels in a retrograde manner to supply its proximal extent. So scaphoid fractures account for 70 to 80%, the vast majority of all carpal bone fractures. And they can happen at any age, although adolescents and young adults are the most commonly affected. And there is a classification system for them. So the Mayo classification states that scaphoid can be fractured at its distal, middle, and proximal extents. And it's this middle extent or waist fractures of the scaphoid, which are by far the most common. So in terms of how they present and how they occur, scaphoid fractures are typically due to an axial loading force of the wrist, and when extension force is applied to the distal pole of the scaphoid, with the proximal pole being stabilized by the radioscaphocapitate ligament, which I mentioned before. So this is most typically a fall on the outstretched hand. Initially, signs and symptoms that suggest a scaphoid fracture are tenderness and pain over the anatomic snuff box, and then swelling and a loss of concavity of the radiodorsal region of the wrist. So if one is suspicious of scaphoid fractures, plain radiographs must be sought, and this is important in putting down in your clinical indications box when wanting to get imaging, because radiographers will take a scaphoid series along with standard AP, oblique and lateral films. So a scaphoid series is when the hand is only deviated to achieve better visualization of the scaphoid. And just like any features of fracture, you're looking for discontinuity of the bony cortex, any linear lucencies, or impaction sclerosis. So other radiographic considerations if a scaphoid fracture isn't seen straight away are features such as displacement of the fracture, soft tissue swelling and lateral displacement of the adjacent fat pads, so a scaphoid fat pad sign, an associated scapholunate ligament injury or disruption, so the Terry Thomas sign, and evidence of avascular necrosis if the fracture is subacute. So as you can see here on the right, we're able to clearly demarcate a scaphoid fracture, whereas down here, it's not actually a scaphoid fracture itself, but it's evidence of this Terry Thomas sign, where you get this disruption in the scapholunate ligament, and this is a poor prognostic factor in scaphoid fractures. So scaphoid fractures are often minimally displaced and therefore very difficult to visualize on plain radiographs at times, and there are reports, from between 5 and 20% of fractures are missed in the acute setting. And this has some important implications for management, which we'll get to in just a moment. But essentially, it's important to acquire follow-up imaging in every patient suspected of having a scaphoid fracture, 7 to 10 days post-injury if they don't actually initially show fracture. A number of other imaging modalities can be used to diagnose scaphoid fractures. CT probably the most notable. They may be used when plain radiographs are NAD, and they're also used for surgical planning if scaphoid surgery is required. And other imaging modalities include MRI, nuclear medicine, and ultrasound. And we can see here on the right an example of a CT scan which demonstrates a scaphoid fracture with an early extent of avascular necrosis shown by the sclerosis. So some important principles of management include consideration of any patient who is suspected of having a scaphoid fracture. If they have negative imaging findings in the acute setting, they should be treated as having a scaphoid fracture. So preferably they're put into a thumb spica cast, as shown here, until a definitive diagnosis is made. So that includes having repeat imaging 7 to 10 days. There are some non-operative features of management, and these are for fractures that are non-displaced by less than 1 millimetre of the distal scaphoid fragment. And so these patients can remain in short arm thumb spica casts for 6 to 10 weeks. Also, patients who have fractures of the waist or the proximal third of the scaphoid and are non-displaced by less than 1 millimetre can also be treated in a similar fashion, followed by an additional period of time in short arm casting until healing is proven, so shown on radiography or other imaging. And so in terms of operative management for scaphoid fractures, there are several. If the fracture is open or the patient demonstrates neurovascular compromise, you'd want to perform surgery. If the fracture is of the proximal 1/5 of the scaphoid, that is an indication for surgery as well. Like we were talking about before, displacement of fractures is an important consideration, and if it's a non-waist fracture that's displaced more than 1 millimetre, or if it's a waist fracture displaced more than 2 millimetres, you'd want to perform surgery. Delayed presentation of acute fractures is important in the context of avascular necrosis, which we'll touch on in just a moment. And fractures associated with scapholunate ligament rupture, so the Terry-Thomas sign on plain film, and or any carpal instability. And so you can see here an example of surgery being performed for a scaphoid fracture that has been poorly united. So just some of the potential complications. The most common reported in the literature is malunion or non-union, and this leads to instability, deformity, and secondary osteoarthritis. And then as well, avascular necrosis due to the blood supply with the distal segment of the scaphoid being supplied before the proximal segment. And so this can be evaluated on multiple imaging modalities, but MRI is the most sensitive. And here's an example with this bright signal suggestive of avascular necrosis. So these are my references, and thank you.